farmasi masa depan dibentuk. Mencegah lebih baik daripada mengobati. Kami bergerak dari rumah ke rumah, dari desa ke kota. Program studi kesehatan masyarakat menjaga banyak jiwa dalam diam.
Kini giliranmu untuk menjadi garda terdepan kesehatan bangsa. Kami datang dari berbagai latar belakang dengan satu tujuan, membawa harapan untuk sesama. Kami belajar untuk merawat dengan hati, karena satu sentuhan bisa memberi rasa aman.
Di balik satu obat yang tepat, ada ilmu, akurasi, dan tanggung jawab yang besar. Program studi farmasi, disinilah calon ahli farmasi masa depan dibentuk. Mencegah lebih baik daripada mengobati. Kami bergerak dari rumah ke rumah, dari desa ke kota. Program studi kesehatan masyarakat menjaga banyak jiwa dalam diam.
Kini giliranmu untuk menjadi garda terdepan kesehatan bangsa. Kami datang dari berbagai latar belakang dengan satu tujuan, membawa harapan untuk sesama. Kami belajar untuk merawat dengan hati, karena satu sentuhan bisa memberi rasa aman.
Di balik satu obat yang tepat, ada ilmu, akurasi, dan tanggung jawab yang besar. Program studi farmasi, disinilah calon ahli farmasi masa depan dibentuk. Mencegah lebih baik daripada mengobati. Kami bergerak dari rumah ke rumah, dari desa ke kota. Program studi kesehatan masyarakat menjaga banyak jiwa dalam diam.
Kini giliranmu untuk menjadi garda terdepan kesehatan bangsa. Kami datang dari berbagai latar belakang dengan satu tujuan, membawa harapan untuk sesama. Kami belajar untuk merawat dengan hati, karena satu sentuhan bisa memberi rasa aman.
Di balik satu obat yang tepat, ada ilmu, akurasi, dan tanggung jawab yang besar. Program studi farmasi, disinilah calon ahli farmasi masa depan dibentuk. Mencegah lebih baik daripada mengobati. Kami bergerak dari rumah ke rumah, dari desa ke kota. Program studi kesehatan masyarakat menjaga banyak jiwa dalam diam.
Kini giliranmu untuk menjadi garda terdepan kesehatan bangsa. Kami datang dari berbagai latar belakang dengan satu tujuan, membawa harapan untuk sesama. Kami belajar untuk merawat dengan hati, karena satu sentuhan bisa memberi rasa aman.
Di balik satu obat yang tepat, ada ilmu, akurasi, dan tanggung jawab yang besar. Program studi farmasi, disinilah calon ahli farmasi masa depan dibentuk. Mencegah lebih baik daripada mengobati. Kami bergerak dari rumah ke rumah, dari desa ke kota. Program studi kesehatan masyarakat menjaga banyak jiwa dalam diam.
Kini giliranmu untuk menjadi garda terdepan kesehatan bangsa. datang dari berbagai latar belakang, dengan satu tujuan membawa harapan untuk sesama. Kami belajar untuk merawat dengan hati, karena satu sentuhan bisa memberi rasa aman.
Di balik satu obat yang tepat, ada ilmu, akurasi, dan tanggung jawab yang besar. Program studi farmasi, disinilah calon ahli farmasi masa depan dibentuk. Mencegah lebih baik daripada mengobati. Kami bergerak dari rumah ke rumah, dari desa ke kota. Program studi kesehatan masyarakat, menjaga banyak jiwa dalam diam.
Kini giliranmu untuk menjadi garda terdepan kesehatan bangsa. Kami datang dari berbagai latar belakang, dengan satu tujuan membawa harapan untuk sesama. Kami belajar untuk merawat dengan hati, karena satu sentuhan bisa memberi rasa aman.
Di balik satu obat yang tepat, ada ilmu, akurasi, dan tanggung jawab yang besar. Program studi farmasi, disinilah calon ahli farmasi masa depan dibentuk. Mencegah lebih baik daripada mengobati. Kami bergerak dari rumah ke rumah, dari desa ke kota. Program studi kesehatan masyarakat, menjaga banyak jiwa dalam diam.
Kini giliranmu untuk menjadi garda terdepan kesehatan bangsa. Kami datang dari berbagai latar belakang, dengan satu tujuan membawa harapan untuk sesama. Kami belajar untuk merawat dengan hati, karena satu sentuhan bisa memberi rasa aman.
Di balik satu obat yang tepat, ada ilmu, akurasi, dan tanggung jawab yang besar. Program studi farmasi, disinilah calon ahli farmasi masa depan dibentuk. Mencegah lebih baik daripada mengobati. Kami bergerak dari rumah ke rumah, dari desa ke kota. Program studi kesehatan masyarakat, menjaga banyak jiwa dalam diam.
Kini giliranmu untuk menjadi garda terdepan kesehatan bangsa. Kami datang dari berbagai latar belakang, dengan satu tujuan membawa harapan untuk sesama. Kami belajar untuk merawat dengan hati, karena satu sentuhan bisa memberi rasa aman.
Di balik satu obat yang tepat, ada ilmu, akurasi, dan tanggung jawab yang besar. Program studi farmasi, disinilah calon ahli farmasi masa depan dibentuk. Mencegah lebih baik daripada mengobati. Kami bergerak dari rumah ke rumah, dari desa ke kota. Program studi kesehatan masyarakat, menjaga banyak jiwa dalam diam.
Kini giliranmu untuk menjadi garda terdepan kesehatan bangsa. Kami datang dari berbagai latar belakang, dengan satu tujuan membawa harapan untuk sesama. Kami belajar untuk merawat dengan hati, karena satu sentuhan bisa memberi rasa aman.
Di balik satu obat yang tepat, ada ilmu, akurasi, dan tanggung jawab yang besar. Program studi farmasi, disinilah calon ahli farmasi masa depan dibentuk. Mencegah lebih baik daripada mengobati. Kami bergerak dari rumah ke rumah, dari desa ke kota. Program studi kesehatan masyarakat menjaga banyak jiwa dalam diam.
Kini giliranmu untuk menjadi garda terdepan kesehatan bangsa. Kami datang dari berbagai latar belakang dengan satu tujuan, membawa harapan untuk sesama. Kami belajar untuk merawat dengan hati, karena satu sentuhan bisa memberi rasa aman.
Di balik satu obat yang tepat, ada ilmu, akurasi, dan tanggung jawab yang besar. Program studi farmasi, disinilah calon ahli farmasi masa depan dibentuk. Mencegah lebih baik daripada mengobati. Kami bergerak dari rumah ke rumah, dari desa ke kota. Program studi kesehatan masyarakat menjaga banyak jiwa dalam diam.
Kini giliranmu untuk menjadi garda terdepan kesehatan bangsa. Kami datang dari berbagai latar belakang dengan satu tujuan, membawa harapan untuk sesama. Kami belajar untuk merawat dengan hati, karena satu sentuhan bisa memberi rasa aman.
Di balik satu obat yang tepat, ada ilmu, akurasi, dan tanggung jawab yang besar. Program studi farmasi, disinilah calon ahli farmasi masa depan dibentuk. Mencegah lebih baik daripada mengobati. Kami bergerak dari rumah ke rumah, dari desa ke kota. Program studi kesehatan masyarakat menjaga banyak jiwa dalam diam.
Kini giliranmu untuk menjadi garda terdepan kesehatan bangsa. Kami datang dari berbagai latar belakang dengan satu tujuan, membawa harapan untuk sesama. Kami belajar untuk merawat dengan hati, karena satu sentuhan bisa memberi rasa aman.
Di balik satu obat yang tepat, ada ilmu, akurasi, dan tanggung jawab yang besar. Program studi farmasi, disinilah calon ahli farmasi masa depan dibentuk. Mencegah lebih baik daripada mengobati. Kami bergerak dari rumah ke rumah, dari desa ke kota. Program studi kesehatan masyarakat menjaga banyak jiwa dalam diam.
Kini giliranmu untuk menjadi garda terdepan kesehatan bangsa. Kami datang dari berbagai latar belakang dengan satu tujuan, membawa harapan untuk sesama. Kami belajar untuk merawat dengan hati, karena 'Karena, 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 'Kar
Di balik satu obat yang tepat, ada ilmu, akurasi, dan tanggung jawab yang besar. Program studi farmasi. Disinilah calon ahli farmasi masa depan dibentuk. Mencegah lebih baik daripada mengobati. Kami bergerak dari rumah ke rumah, dari desa ke kota. Program studi kesehatan masyarakat menjaga banyak jiwa dalam diam.
Kini giliranmu untuk menjadi garda terdepan kesehatan bangsa. Kami datang dari berbagai latar belakang, dengan satu tujuan, membawa harapan untuk sesama. Kami belajar untuk merawat dengan hati, karena satu sentuhan bisa memberi rasa aman.
Di balik satu obat yang tepat, ada ilmu, akurasi, dan tanggung jawab yang besar. Program studi farmasi. Disinilah calon ahli farmasi masa depan dibentuk. Mencegah lebih baik daripada mengobati. Kami bergerak dari rumah ke rumah, dari desa ke kota. Program studi kesehatan masyarakat menjaga banyak jiwa dalam diam.
Kini giliranmu untuk menjadi garda terdepan kesehatan bangsa. Kami datang dari berbagai latar belakang, dengan satu tujuan, membawa harapan untuk sesama. Kami belajar untuk merawat dengan hati, karena satu sentuhan bisa memberi rasa aman.
Di balik satu obat yang tepat, ada ilmu, akurasi, dan tanggung jawab yang besar. Program studi farmasi. Disinilah calon ahli farmasi masa depan dibentuk. Mencegah lebih baik daripada mengobati. Kami bergerak dari rumah ke rumah, dari desa ke kota. Program studi kesehatan masyarakat menjaga banyak jiwa dalam diam.
Kini giliranmu untuk menjadi garda terdepan kesehatan bangsa. Kami datang dari berbagai latar belakang, dengan satu tujuan, membawa harapan untuk sesama. Kami belajar untuk merawat dengan hati, karena satu sentuhan bisa memberi rasa aman.
Di balik satu obat yang tepat, ada ilmu, akurasi, dan tanggung jawab yang besar. Program studi farmasi. Disinilah calon ahli farmasi masa depan dibentuk. Mencegah lebih baik daripada mengobati. Kami bergerak dari rumah ke rumah, dari desa ke kota. Program studi kesehatan masyarakat menjaga banyak jiwa dalam diam.
Kini giliranmu untuk menjadi garda terdepan kesehatan bangsa. Kami datang dari berbagai latar belakang, dengan satu tujuan, membawa harapan untuk sesama. Kami belajar untuk merawat dengan hati, karena satu sentuhan bisa memberi rasa aman.
Di balik satu obat yang tepat, ada ilmu, akurasi, dan tanggung jawab yang besar. Program studi farmasi. Disinilah calon ahli farmasi masa depan dibentuk. Mencegah lebih baik daripada mengobati. Kami bergerak dari rumah ke rumah, dari desa ke kota. Program studi kesehatan masyarakat menjaga banyak jiwa dalam diam.
Kini giliranmu untuk menjadi garda terdepan kesehatan bangsa.
greenhouse where various herbs are grown for research purposes. And of course, we have a state-of-the-art lab where we can conduct experiments and research. For those who take nursing as your major, you will get the chance to see the Japanese corner. This is specially designed for nursing students because they have the opportunity to work in Japan in the future if they want to. Another amazing facility that we have is our computer lab and our drugstore simulation.
In this room, we get to practice our skills as pharmacists and learn how to use software and equipment related to our field. Here, we get to practice with simulated patients and prescribe them the appropriate medication. Okay, that's all about my college. I hope you enjoyed this video and learned something new. Thanks for watching.
Good morning, ladies and gentlemen. The conference is about to begin. Please kindly turn off your microphone during the conference. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera bagi kita semua. Shalom, Om Swastiastu, Namo Buddhaya, dan salam kebajikan. Ladies and gentlemen, distinguished guests, honorable speakers, and esteemed delegates. Good morning and welcome to the third Cendekia International Conference on Health and Technology 2025 with the theme of Palliative Care, a holistic approach to addressing the needs of patients with life-limiting illnesses. It is an absolute pleasure to have each and every one of you here today, representing a diverse range of backgrounds, expertises, and experiences. Allow me to extend our warmest greetings to our eminent speakers and guests. Respectable Dr. Ani Megawati, Bachelor of Pharmacy, Registered Pharmacist, Magister of Science, as the Interim Rector of Cendekia Utama Kudus Health and Technology Institute. Honorable Professor Alison Hatton, Registered Nurse, Diploma in Applied Science of Nursing, Bachelor of Nursing, Paid Certificate, Master of Nursing, PhD, Fellow of the Australian College of Nursing from Western Sydney University. Honorable Dr. Haliza Abdul Rahman, PhD from University Putra Malaysia. Honorable Dr. Nazir Ahmad, Diploma of Pharmacy, Master of Philosophy, PhD, Registered Pharmacist from University Islamabad Campus, Pakistan. And unforgettable, the heads of departments, heads of study programs, lecturers, students, and invited guests who have attended this event. I would like to express our sincere appreciation for the support and guidance provided by our distinguished guests. Your willingness to share your expertise through keynote speeches, panel discussion, and interactive session is a testament to your commitment to the betterment of our global community. Firstly, let's pray and thanks into our God, Allah Subhanahu wa Ta'ala, who gives us mercies and blessings, so we can attend and gather in this place with good condition and happy situation. Secondly, may salawat and salam always be with our Prophet Muhammad Sallallahu Alaihi Wasallam, who has guided us from the darkness to the brightness, namely Islam. Ladies and gentlemen, I am Fika Izati Fizla as the Master of Ceremony, and it is my privilege to guide you through this captivating event. Without further ado, let me read out our agenda for this morning. First, opening. Second, singing the national anthem of Indonesia, Indonesia Raya, and then opening speech, continue by photo session. After that, material presentation and panel discussion, and the last agenda is closing. The first agenda is the opening. To begin this event, let us recite the Tasmiyah together. Bismillahirrahmanirrahim. May Allah bless this conference and make it a success. We will now proceed to the second agenda of our conference, singing the national anthem of Indonesia, Indonesia Raya, and followed by singing March of Cendekia Utama Kudus Health and Technology Institute. Please join us in showing our respect and appreciation for our host country. Hadirin dimohon duduk dengan sempurna.
kesehatan lahir batin, dambaan semua, beramal bagi sesama, langkah mulia, membina cendekiawan bangsa, berperan nyata, Itekas Cendekia utama, semoga selalu jaya, kampus kebanggaan kita, Cendekia utama. Cendekia utama kudus, kampus tercinta, mencetak generasi unggul, berakhlak mulia, berjuang untuk negara, nusa dan bangsa. Itekas Cendekia utama, semoga selalu jaya, kampus kebanggaan kita, Cendekia utama.
The third agenda is opening speech. The speech will be delivered by the Vice Rector for Collaboration and Alumni Affairs of Cendekia Utama Kudus Health and Technology Institute. He is Mr. David Laksamana Kesar, Magister of Public Health. We are honored to have him here with us today. Mr. David Laksamana Kesar, please. Mr. David, please.
Baik, thank you for Master of Ceremony. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi
wabarakatuh.
Good morning, distinguished guests, esteemed colleagues and friends. Honorable Professor Lyson Hatton from Western Sydney University, Honorable Dr. Halisa Abdul Rahman from University of Putra Malaysia, Honorable Dr. Nazir Ahmad from University Islamabad, Pakistan, and Honorable all panelists, delegate, lecturer, and student present in this conference. First of all, let us give thanks to Allah Subhanahu wa Ta'ala for His blessing and guidance. I am grateful for the opportunity to speak to you all today. And also, I want to thank the Master of Ceremony for giving me the opportunity to deliver the speech. It is a profound honor and privilege to welcome you all to the Cendekia International Conference 2025, an international gathering dedicated to advancement of palliative care, a field that lies at the very heart of human dignity, compassion, and holistic healing. We are truly grateful for your presence here in Kudus, Indonesia. Whether you have traveled from across the globe or join us virtually. Your commitment to improving the quality of life for patients and families facing serious illness is both inspiring and deeply needed in today's world. Ladies and gentlemen, on behalf of the organizing committee, I extend a warm welcome to our esteemed speaker, panelists, delegate, lecturer, practitioners, and students who have come together to share their knowledge, insight, and innovation in the spirit of collaboration and progress. This conference is more than a meeting of professionals. It is a convergence of empathy and expertise, of science and soul. Over the next few days, we will explore clinical innovation, share the practice, discuss pressing challenges, and perhaps most importantly, remind ourselves of the sacred responsibility we carry in alleviating suffering and honoring life until its very end. Palliative care is not just a medical specialty, it is human right, and through collaboration, research, education, and advocacy, we can ensure that every person, regardless of age, diagnosis, or geography, has access to the compassionate care they deserve. Ladies and gentlemen, let me take this opportunity to thank our eminent speaker, presenters, moderators, and all participants for your invaluable contribution. Special gratitude goes to our partners, sponsors, volunteers, and the organizing committee who have worked with such dedication to bring this event to life. May this conference be a space for learning, connection, and renewed purpose. I encourage you to share your insight, listen deeply, and carry forward the wisdom we build here into your own communities and care setting. Ladies and gentlemen, once again, welcome, and may our time together be as meaningful as the mission we share. Thank you very much for coming along here today. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you to Mr. David Laksamana Kaisar for the speech. Ladies and gentlemen, for the fourth agenda, we will have a photo session. To all the distinguished guests, honorable speakers, and esteemed delegates, I request to be prepared and smile for the camera. Please look at the camera and give us your best smile. Hold and wait for a minute. Let's start from slide 1. 3, 2, 1. And then start 2, 3, 2, 1. Slide 3, 3, 2, 1. And the next slide, 3, 2, 1. Now, we have reached the main part of the event, which consists of the material presentation and panel discussion. The moderator will take over the session from this point. Before that, I would like to introduce the moderator of today's conference. She is Mrs. Arina Hafadzotul Husna, Magister of Education, a lecturer of English and Japanese language in Cendekia Utama Kudus Health and Technology Institute. She finished her magister degree of English education at Semarang State University in 2015. And now, she is the leader of Language Center of Cendekia Utama Kudus Health and Technology Institute. Please welcome Mrs. Arina Hafadotul Husna. The floor is yours.
Okay. Thanks to our Julius Master of Ceremony for the time given to me. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Alhamdulillah wa syukurillah la hawla wa la quwata illa billah amma ba'd. Respectable Dr. Ani Megawati, Bachelor of Pharmacy, Registered Pharmacy, Magister of Science as the interim rector, and all of the vice rectors of Cendekia Utama Kudus Health and Technology Institute, Honorable our invited plenary speakers, Associate Professor Dr. Halisa Abdurrahman PhD from University Putra Malaysia, Dr. Nazir Ahmad, Diploma of Pharmacy, Magister of Philosophy, PhD, Registered Pharmacist from University Islamabad Campus, Pakistan, Professor Alison Hutton, Registered Nurse, Diploma in Applied Science of Nursing, Bachelor of Nursing, by Certificate, Magister of Nursing, PhD, Fellow of the Australian College of Nursing from Western Sydney University. Unforgettable, the heads of department, heads of study programs, lecturers, students, invited guests, and distinguished participants who have attended to this event. Ladies and gentlemen, this conference is about to begin. Please kindly turn off your microphone during the presentation. I am Arina Hafadotul Husna. It's a great pleasure to be the moderator, and it's an honor for me to welcome the remarkable speaker and all the audience to the third Cendekia International Conference on Health and Technology 2025 with the theme Palliative Care, a holistic approach to addressing the needs of patients with life-limiting illnesses. Before starting this conference, let me quickly go over to the agenda. It will begin with a brief introduction of our speakers, followed by the presentation, which is about 30 minutes for each. Then it will continue by panel discussion, question and answer session for about 30 minutes. And the last agenda is closing. Ladies and gentlemen, without further ado, let's start our today's conference. I'd like to introduce our first speaker. She is Associate Professor Dr. Abdurrahman PhD. Dr. Halisa is an academic at University Putra Malaysia, or it well known as UPM, serving in departments of Environmental and Occupational Health, Faculty of Medicine and Health Sciences. She is also the head of the Laboratory of Leadership, Politics, Citizenship at the Institute for Social Science Studies, and his research focuses on environmental and health governance, public participation, sustainability science, and also environmental law and policy. Her work also emphasizes community engagement, especially involving youth in environmental and disaster-related education. Dr. Halisa is a prolific researcher with over 300 publications. Many of them are available on her ResearchGate profile. Her research spans a wide range of topics, including environmental health, food waste management, disaster education, occupational safety, environmental sustainability, and public attitudes toward environmental protection. She is also actively involved in public education and policy advocacy, contributing to national discussion on mangrove forest conservation, water management, and sustainable urban planning. Ladies and gentlemen, please welcome Dr. Halisa Abdurrahman, PhD, to start the presentation. Dr. Halisa, the time is yours.
Thank you very much, Mr. Moderator. Mrs. Moderator. Okay, Assalamualaikum and very good morning to all. Yeah. Okay, as mentioned by moderator, my name is Haliza from UPM. So I would like to share my slide. Okay, can you see my slide?
Not
Not
yet.
yet.
Yeah.
Okay.
Not yet, madam.
Yeah.
Okay, now everybody can see my slide.
Yeah.
Okay. But I'm sorry because my slide is in Malay, but I can explain in English as well. So I think this is a very important seminar for us and also for the rest who involved in the health sector because the palliative is very important issue regarding when we touch on the patient wellness. Okay, I will focus the palliative for the patient of NCD, non-communicable disease in Malaysia. So in Malaysia we call penyakit tidak berjangkit. In Indonesia you call penyakit tidak menular, or in English we call NCD. So NCD we know have a variety of the illness. For example, heart attack, stroke, cancer, and so on and so forth. So and also the non-communicable disease is the illness which cannot simply spread to everybody. Is not like the CD, communicable disease. This type of illness is because of the lifestyle and also contribute by the genetic. So in Malaysia, actually, NCD is one of the main disease which contributed to the death and also wellness of the patient. So this situation is very is worried because they can affect the individual health and also can burden the country economics and also the public health system. So you can see in here, as mentioned, as reported by the WHO, the case for the Malaysia is around, the cost is around 64.2 billion or 4.2% of our KDNK or our per capita, including 12.4 billion ringgit for the cost of take care of the patient, and also this also contributed to 51.8 billion because loss of productivity of the patient because they cannot work as they have their some kind of diseases. So 60% of the death in 2025 also in Malaysia is because of the NCD. For the main one is because of the heart attack. The rate is 1.2.8% per 100,000 population, and also the second one is because of the stroke, 80.5% out of 100,000 of population. And also prevalent for NCD also increasing, which we can see here, 56% of the adult have obesity, 33.3% have highest cholesterol, and also 29.2% have the hypertension, and another 15.6% have diabetic. So you can see here in Malaysia, NCD contributed a lot of burden, not only into the health, but also into the economics. So in sample, we have around 2.8% or 500,000 of the adult have 4 types of NCD when we touch on their health. For example, hypertension, diabetic, cholesterol, and also the obesity. So this is the main NCD in Malaysia. Okay, as I mentioned, you can see diabetic. Here 50.6%, and also another illness because of the diabetic. So cancer also one of the main diseases. The main one is the breast cancer and also colorectal cancer. And also another type of disease on NCD is the chronic respiratory disease, especially the asthma and also the COPD because of the smoking habit and also the air pollution. So another NCD which need to be focused, I think not only in Malaysia but the entire world, including Indonesia, is the mental health. We know now the issue of mental health is increasing, very huge in around the globe. Yeah. So in Malaysia, 1 out of 3 youth have and also 1 out of 4 of adults have stress because of the mental health. And this one Indonesia categorized as NCD on the neuropsychiatry by the WHO. And the main one is because of the depression and also anxiety. So why this issue need to be focused? Because in Malaysia, NCD, as I mentioned, contributed a lot when we talk regarding the health of the society, economic productivity, and also the sustainable of the healthcare system in our country. So because the first one, why we need to focus in this issue, because this can contribute to the debt and also a loss of their productivity. In Malaysia, 65% of the debt is because of the NCD. And also in here, more than 50% of the individual not really know that they have this type of NCD until they have the very final stage, very serious stage, which we cannot do anything regarding that. Second one, why this issue need to be focused, because the burden to the economy is very huge, whether indirect or indirect. So as example, in 2021, NCD contribute around 64.2 billion, including the treatment costs, the loss of the productivity of the workers, and also premature of the debt. The third one is because this type of disease is increasing slowly and also continuing. We call this type of disease is the silent killer. So because they can be increasing without the symptom, very early symptom. So in Malaysia, actually, our society not really like to have help examination or health care detection in early stage. And this disease only can be detected on the 3rd or 4th stages, which is very late. Another one is because of the lifestyle of the society is not really take care of their health. So the lifestyle, which more and more of the youngster and also the youth, including the adult, have not really practice the very good healthcare in their daily life. The taken of the food, especially the sweet drink. We can see in our society, we have so many premise which sell the sweet drink in a variety of the brand, and also taken very high of the instant food in their daily life, because of another factor is less physical activity, stress because of their work, and also the smoking habit, plus the alcohol consumption, this and also obesity. This all contributed to of the not very good lifestyle. So in Malaysia, 50% of our adults have obesity, which 1 out of 5 have diabetic. So this need to be focused not only in Malaysia, I think in another country. So another factor why this is very important, because this type of NCD can threaten our future generation. So in our country, more and more of the youth and also the children have obesity and also have the diabetic type 2, which is rarely happen previously. Okay, and 80% of adults which the age 18 and 29 years with diabetic did not know they have the disease, and also this can have a very risky health effect to their health. So now we can see around the globe in our country also the report from the Ministry of Health. So previously we know the NCD is happen in the adult with the late age 40 above, but now we can detect this type of disease to our youngster as early as 20, 30. Okay. Then when more and more of our society have this type of NCD, so this can be affected of our health system. So we know hospital must take care of so many diseases. So this type of NCD can increasing the burden of the especially government hospital to take care of the patient with this disease. And also Malaysia as well as other country also have huge burden to take care of this type of patient, which is increasing rapidly. Now here you can see the latest statistic of our NCD in Malaysia. 70% of the that is because of NCD reported by 2023, and prevalent of this disease, the main one is diabetic, hypertension, high cholesterol, obesity, and other comorbidity, which they have more than one of the NCD. So 2.3 million of adults have at least 3 type of NCD disease. As example, diabetic plus hypertension and also high cholesterol. And 500,000 population have more NCD in their health. So this is very important because we have so many patients with NCD. So we need to take care of their health and also wellness. So the palliative is really need to be focused for them to less burden to our health system and also the hospital. So actually in Malaysia regarding NCD, we have currently practice the clinical treatment and also awareness and also early detection. But the challenges is the less awareness of the society. The treatment is not holistic and also the very weak of the monitoring. So in Malaysia, now we focus to the holistic approach regarding taking care of the NCD patient. And we focus to early detection, the prevention, the intervention, to make sure we can decrease the number for the potential individual who can get this type of disease. So we focus on the holistic. The first one is very common. We give a medicine and also we have early detection. So in Malaysia, we focus on the prevention and control of NCD. In Malaysia, we have report the case for investment. So including the less taken of the salt, control the tobacco, promotion of the physical activity, and also increasing in cancer. Early detection of the cancer, especially breast and also colorectal. And also we the Ministry of Health now have enforcement which all the product regarding the food, the drink product must have the label which in label we can see the percentage of the sugar of the and also the salt, the everything so when we want to buy we can read and we can think whether we want to buy or not because they this kind of food can affected of the consumer. And also the very important one is increasing regarding early detection and also now we have free early detection regarding how to detect the BP the sugar, cholesterol, and another type of system to detect very early stage so we can control this. And also the screening of HPV. So in Malaysia, we mandatory So HPV DNA must be detected for the woman every 5 years, and it's free. Okay. And also another one, we practice the model of the communication treatment and multidiscipline, share decision making also with the patient doctors to decrease the treatment of NCD, have more autonomy to the patient, and also to increase the how they can very consistent follow their treatment, and also collaborative care teams which include so many stakeholders, example the cardiovascular expert, the nurse, the dietitian, support from their peer, and also very comprehensive hospital management, and also the community. Another one is now we digitalize and transform the health system to less burden of our health system. Yeah, so now we using apps we call My Sejahtera regarding that, all digitalized, and also application of the electronic medical record in 22 hospital, and also 206 clinic CCM in 78 clinic in national, and also diagnosis related group. This is part of our digitalized. And also now the important one we need to focus is the involvement of the community and also the voluntary. So we have the clinic advisory panel, which 9,800 of the community involved, which they can be a bridge or we call a person which can continuing between the clinic and the community to promote the very good health practices and also wellness in daily life. Focus on NCD. Okay. And another one is the because we know when we talk about health, this involve a lot of money, the cost. So now we focus also on the monetary and also access to the treatment. So we have the system we call scheme Perubatan Madani. We subsidize the medicine and also free consultation, especially to the poor one. We call B40. Which have the disease such as a diabetic and also hypertension. And also we have one department we call Jabatan Kebajikan Masyarakat, the Welfare Department of Malaysia, which give a support regarding the monetary to buy some of the instrument, as example the wheelchair, and also regarding the cost on treat of the chronic disease of the patient. So this is the summarize of the current practice of how we treat of our NCD patient in Malaysia, as I mentioned. And now we focus on the palliative. I think all of us know what is palliative. So the palliative is very important, especially to release the stress, the anxiety or depression of the patient which diagnosed with NCD, especially in stage 4, which they don't have maybe opportunity to long life. So this can increasing the quality of the life of the patient. So this focus on the final stage of the cancer patient, which also including the heart attack problem, lung, and also the kidney problem in the final stage, and also the degenerative of the nerve of the patient, focus on Alzheimer and also Parkinson, and also to the kidney patient who already stopped their dialysis. And in Malaysia, we know that our palliative is need to be focused because, as I mentioned, of the burden of the NCD disease is increasing very huge in our country. So we need instead of the treatment, we also need to focus of the palliative of the very I think very good very needed treatment to the final stage of the patient for with the very dangerous NCD. So why we need to have a palliative treatment in Malaysia? As I mentioned first, because increasing of the chronic diseases of the patient, and also because we have now towards the aging country. As we know, when we have aging country, so we need to treat the aging people with the NCD disease. So by 2030, 15% of Malaysian be 60 years old, and that can be contributed to the NCD, which increasing our burden to the health system. And statistic by 2023 detected that more than 180,000 of the final stage of the cancer need palliative treatment. However, only 10% get it. So this is very low regarding the percentage to the patient. And also, when we have palliative, we can decrease the burden of the emotion and also physical of the patient regarding take care of their health. Because we know when we have the illness or disease at the final stage, so they have suffered because of their disease, and also they have lonely, maybe stress regarding the emotion. And also palliative is very helpful regarding how to arrange all these the symptom and also given psychosocial support and also spiritual support to the patient. And also palliative can be decrease the burden, the long burden to the hospital regarding this type of another treatment, and also decrease the cost regarding how to take care of the patient. So palliative, which focus on the take care of the patient health in the house and also hospice, can be decreased the admission of this patient to the hospital. And the study show that the palliative treatment can be decrease the cost of the final stage of the treatment between 30 and 40%. This is a lot when we talk about the health system. And also palliative also can have support to the caregiver of the patient and also the family for the patient. Because with the palliative, we can treat their caregiver or whatever, their family, how to take care of the patient with the training, and also with the some of the very important treat to them. And also palliative also contribute counseling, the grief counseling regarding their sad and also their plan until the end of their life. And however, we also have the challenges regarding the palliative in Malaysia. First one is, as mentioned, the very limited access. Only 6% of government hospital and 3 hospice and NGO have palliative treatment in full. The second one is we have not enough of the expert regarding the palliative. Only 20 palliative have in our country, around the country, only 20 expert which very really recognized regarding palliative in our country. And also another one is the stigma and also the less awareness, because some of the patient thinking that when we talk about the palliative, this is they cannot do anything, just wait until the end of the life. So this is another stigma need to be important thing, need to be focused. And also regarding that, so our government, especially in Ministry of the Health, have the current initiative, which they have already have a strategic plan regarding the palliative release with a long duration, I think 2090 until 2030, which focus the plan strategic regarding the palliative service. So in here, they have a huge training to the primer staff of the health regarding the basic of palliative. They also have a palliative unit in every district hospital regarding to train to make sure that our patient can be really get the treatment or training whatever, and also involve joint venture with the NGO, as example the Hospice Malaysia regarding the palliative. And also another one is focus on the community support, and also the house care regarding the patient also increasing very huge. So actually when we call the palliative, the treatment of NCD, not only must focus on also the two treatment as usual, which is the clinical treatment and also pharmaceutical, but the palliative is very important, especially with the patient with the final stage of their life, the stage 3 to stage 4. So palliative is not focused on to cure the patient, but to increase the quality of life of the patient in how to manage regarding increasing their painful, decreasing of their emotional stressful, and also daily of their daily difficulty regarding their health of chronic disease. So in here, we also have the one of the good case study in Selayang Hospital, which this woman have the final stage of the breast cancer. So when this patient have their palliative treatment, so this is a lot helpful the patient with the emotion, and also how to control the stressful, especially, and also the painful of the disease. Okay. So for the solution, in Malaysia, when we talk regarding the challenges, we also need to have a solution for that. So for solution, so we need to make sure that palliative can be distributing the whole of our country, especially to the isolated area, and also maybe the rural area, and also increasing regarding the training to the health professional regarding palliative, and also increasing the awareness on the public, what is palliative, what is the important and also significant of the palliative. And also another one which is very important is involvement of the NGO and also the local community. So as a conclusion, actually, when we talk about palliative, this is not only for the stage 3 or stage 4, very critical stage of the patient, especially with the cancer. But for the whole of NCD patient, which have stressful regarding their physical, emotional, and also spiritual. And also this is very important regarding palliative to be part of our health system in Malaysia, which in future maybe with all the mitigation, we hope that the patient with the final stage of their life can be we call bermaruah. I mean, can be not really have stressful regarding of the health or the disease which they have and can be routine daily life they can practice the very good condition to less all the burden because of the disease. I think that's all. Thank you very much.
Okay, thanks a million to Dr. Halisa for the great and rich information through the presentation. Thank you. Okay, ladies and gentlemen, we are going to have our second presentation. Our second presenter, is Professor Alison Hutton, registered nurse, diploma in applied science of nursing, bachelor of nursing, by certificate, magister of nursing, PhD, fellow of the Australian College of Nursing from Western Sydney University. Prof. Ali is now a conjoined professor in nursing, School of Nursing and Midwifery, University of Western Sydney or Southwestern Sydney Local Health District, who is concerned with teaching, research, administration, and professional or community activities. Would you please help
Okay.
me? Yeah, okay.
Can I
And
share my
then
screen, please?
Yes.
Thank you.
And Professor
Thank you.
Ali finished her Bachelor of Nursing, Master of Nursing,
Oh,
and
okay.
also her Doctor of Philosophy at Flinders University. And she is also prolific researcher who has written many books, report, and have so many publications, national and international publication actually. And her research is cited more than 3,500 citations. And since 1999 until now, she has won so many awards, and her latest award is becoming a top 20 scientists, 20% scientists at Stanford University, especially related to public health. Ladies and gentlemen, allow me to welcome Professor Ali to present the material. Prof. Ali, the time is yours.
Selamat pagi, everybody.
Yeah, good morning.
Namaste, Ali.
Oh, yeah. Can you speak
I just-
Indonesian?
That's it.
Yeah.
Actually, I just need to make sure with my sharing of screen, hang on, I'm very sorry, with my sharing of screen that I've got the sound on because I've got some videos. So let me just quickly just double check. Sorry, share sound. Hang on, done that. Okay, all good. So good morning, everybody. My name's Ali. How are you? I will get up my presentation again. Apologies. So that is it up there now?
Yeah.
Yeah?
Yes,
Okay,
yeah.
hang on. I've just got to minimize. Okay, I can see it. Yes. So thank you very much for having me. Thank you to Indri for inviting me. So it's been a long time since I've seen you, but thank you for the invitation. It's always nice to connect with old friends. Today I'm going to talk about family-centred nursing care and the rights of the child in palliative care. And hopefully my videos will work and the screen will move forward. So we'll see how we go. Perfect. So today I'm going to talk about to set the tone of this lecture, I'm sorry. Everyone who is here right now and who works in the paediatric setting knows that we cannot care for the child without interacting with the child within the family unit. And we want those interactions to be positive and we want them to be meaningful for the child and for the family. So today I'm going to explore two pillars of paediatric palliative care, that one being family-centred nursing and the other being the rights of the child. These principles not only guide clinical decisions, but they also shape compassionate, ethical care that respects both the children and their families during one of the most vulnerable times of their lives. So let's quickly talk about palliative care. So paediatric palliative care is a specialised medical care for children with serious illnesses. And this can include cancers, but it can also include diseases such as liver disease, kidney disease, heart disease. And we know that during palliative care, we're really focusing on the quality of life that's left for that child. We want to provide symptom relief, psychosocial support, and spiritual care. The group of patients are likely to have been in and out of hospital for many, many years before they come to us. So we need to think about how we can leverage their past experiences as a patient, and we also need to use their intimate knowledge of themselves and their bodies to enhance their own care. So I'm going to talk about the physical, emotional, social, and spiritual needs of the child and the family as well, because all of us know that work in the paediatric setting, the child and the family are connected. We know that caring for the child who is dying is one of the most sensitive and complex responsibilities that we can have as nurses. We need to be compassionate, and we need to honour the child and the family's full humanity. So to ensure these needs are addressed, we must make sure that our care is comprehensive and deeply personalised. It's not a one-size-fits-all. We also need to care for and understand the intelligence that the family brings to this care, which means we need to understand that they understand the child. Recent studies have shown that a parent, mothers especially, can notice a deterioration of their child's condition 7 hours before a nurse. And that is astonishing. That's nearly a whole shift. So as nurses, how can we use that information to provide better care? So due to the nature of nursing, we can sometimes put the physical needs first. And in palliative care, this does make sense because comfort and symptom management can increase longevity, but it can also provide and create trust. And we also want that sense of safety for the child and the family by effectively managing the child's pain, their symptoms. The nurses build a foundation of comfort that allows space for emotional, social, and spiritual care to unfold. When physical suffering is relieved, children and families are more open to meaningful conversations, connections, and moments of peace. And this holistic approach not only enhances the quality of life, but affirms the child's dignity in their final days. Immediate physical needs do tend to include pain management, hydration, nutrition, positioning, and controlling the overall environment. But pain management is not just to reduce pain, it's also to reduce agitation and other distressing symptoms like nausea, breathlessness, and agitation. But we can never forget the non-pharmacological interventions. They're just as important. We need to think about how to position the patient appropriately and also how to use supportive devices to prevent pressure sores and enhance comfort. And these niceties are just as important as medications. And lastly, when we think about physical needs, we also need to think about the environment. We don't want the child and their family to be in a noisy, busy ward. We actually would like them to be somewhere that's calm, soothing. We might like the ability to dim the lights, create some quiet sounds, and let the child be surrounded by their own personal belongings, things that create a comforting atmosphere for them, not for the nurse. So I'm going to move on to emotional needs. And after this, I'll play a quick video and hopefully it'll work. So we need to provide age-appropriate open communication, and that's probably one of the most important things. And we need to do that to develop a strong and trusting relationship with the child and their family. But people that work with children, we know that the parents will advocate for the child, especially when they're younger. So we need to make sure that we have a relationship with the parents. It's important to allow both the child and the parents to ask questions, express their fears, and say what they need. And we don't need to provide a solution. Sometimes listening and allowing the patient and the family to feel heard is enough. So when we communicate, we need to do our best to engage in open, honest, two-way dialogue, which encourages the child to express their fears, their thoughts. And that can be really hard when you have a patient that's dying. But this approach promotes trust, understanding, and a strong bond between parents and their children. We want to emphasise listening, empathy, and respect as the key components. It's about creating a safe environment where the family and the child feels valued and heard. And, you know, sometimes for the health professional, this can be quite a lot. So they also need to have support and they need to be able to debrief and talk to someone. So I'm going to show you a quick video. As I said, hopefully it'll work, on the 4 principles of communicating with your child. And look, if it doesn't work, just yell out and then we'll move forward, but we'll give it a go. Okay, here we go. Fingers crossed. Is that okay?
There is no voice. Soundnya. I can't hear the sound.
Can't hear?
Yeah.
You can't hear it?
Not yet.
Can't hear it? Can't hear it at all?
Yeah.
Okay.
We
All right.
can't.
Well, you can?
Yeah. Cannot.
Cannot.
Cannot. Yeah.
Okay. All right. All right. So what this video was talking about, don't worry about it, we'll move on to the next, is about validating what your child says, that it's really important just to, hang on, I gotta go to the next screen. To validate what your child says, let them laugh, let them cry, let them be silent if they want. You know, you don't have to make them talk. You don't have to make them be happy. You can just let them be, and that's really important. And also, a really important thing around providing emotional support is letting the child draw, journal, make things that make them happy. So we call it memory making, and the family can be included in that, or the child can do it on their own. But these kind of activities provide emotional support and kind of a focus in the hospital. Now, I have 2 more videos and I'll just skip past them just so you know. So when we talk about social needs, one of the things that happens when children are in the healthcare system for a long time is they lack social time. And social time is really important as it helps the child remain connected with their siblings, their friends, and trusted adults. So if people can't visit due to medical needs, then you can provide video calls, you can ask people to write letters, send in drawings, pictures, and those kind of mechanisms help the child feel connected. Another part of connection and inclusion is letting the child make as many decisions as they can in the daily care. So even though they may seem young, you can direct the question to the child and the parent can still answer, but you're still including the child by directing the question to them. And of course, social support will extend to the family. So you need to think about how you can provide some resources to parents, siblings, etc., to extend care. All right, now I'm having trouble. We'll go to the next one. Okay, hang on. Sorry, everybody. Here we go. Spiritual needs, that's better. Okay. So the other thing that I think is really important to talk about is the spiritual needs of the child, and we need to allow both the child and the family to explore their spiritual beliefs in a safe manner. So having a child that is palliative will most likely challenge the child and their family members to explore their belief systems. So we need to give them time and space to do that. So in Australia, many hospitals have chaplains or religious leaders to support and guide the family where appropriate, and supporting spiritual rituals, whatever they are, helps the child and the family reflect on their life, keep on developing relationships and create meaning, even if the child is very young. So the overall goal of palliative care is to treat the child with respect and dignity, which of course means seeing the child as a whole person. We need to provide care that's culturally sensitive and respects cultural and religious beliefs. Another part of care is ensuring that care is provided in a trusted setting. And some of the things that we do now in Australia, which I'm sure you do in Indonesia as well, is provide care in the home setting. We don't bring people into the hospital if we don't need to. So the goal of both palliative and family-centred care is to minimise suffering, preserve dignity, and foster peace and comfort for the child. We believe that every dying child deserves to feel safe, loved, and comforted, not alone and afraid. So supporting their whole self helps their family carry lasting memories and a sense of meaning. So what is family-centred care? So family-centred care is an approach to healthcare that recognises that the family is the constant in the child's life, not the hospital staff, and values the family's knowledge, their strengths, and their culture. So the core principles of family-centred care does really align with palliative care. They are respect and dignity, information sharing, participation, and collaboration. And what that means is we respect the dignity and we honour the family's values, beliefs, and cultural backgrounds, even if they're different from our own. In regards to information sharing, we provide complete and unbiased information in a supportive manner, and be mindful that at times that the family just might not be ready for the information, but we need to be ready when they want to ask us. We've talked about participation already, and that's encouraging families to participate in care and decision making at a level that they choose. And lastly, collaboration, which is really the important part here in regards to care delivery. More and more in Australia, we turn to our consumers now and ask them to collaborate in policy and program development so that we understand their needs during this distressing and often painful time. So just really quickly, because I know you can't read this, this is a new policy that we have just developed in South Western Sydney Local Health District, and I'm happy to share it with you later if you like. But basically, these child safe policies are essential to our organisation. They aim to prevent and respond effectively to the needs of the child, ensuring a safe, supportive environment, whatever it means to them. So this policy promotes the safety and wellbeing of children in the local health district. It applies to all health facilities and services, including services where adults are the priority. Our health district has the largest amount of children in all of Australia, and it's quite a growing and multicultural area. So the application of family-centred nursing to palliative care is it ensures the child and the family remains at the centre of our care. It means in end-of-life care scenarios, families are supported in their grief, their legacy building, and their cultural rituals. One example that I mentioned before is a child might wish to make a memory box, and we'll do whatever we can to make that happen. And this kind of activity will help the child deal with their grief, create a memory, which of course creates legacy, and cultural rituals can be included. And those kind of things provide comfort and solace. So just moving on to the rights of the child in palliative care. And just so you know, all of these photos that are coming now are mine when I'm in Indonesia. So I have permission of the children, just so you know. So in regards to the rights of the child, there are many foundational frameworks that we use in Australia, and we still really refer to the United Nations Convention of the Right of the Child, 1989, and really, you know, as I've been talking about, that emphasises the child's right to be heard, respected, and protected. And there's 4, maybe 5 articles that we would refer to. Article 12, the right to express views in all matters affecting the child. Article 13, freedom of expression. Article 24, the right to the highest attainable standard of health. Article 27, the right to a standard of living adequately. And Article 31, the right to rest, leisure, and play. And even when the child is dying, it's still important to provide these principles and care. So what are the implications for practice? So we want children to be included in all decisions where appropriate. We want care to respect their developmental stage and also their communication style. We want healthcare to be non-discriminatory. And we want an emphasis on holistic care, addressing pain, anxiety, fear, etc. So I did have another video, but I'm going to skip it. So we're skipping that. And we're just going to quickly, in closing, start to just talk about some ethical principles. And one of them is assent versus consent. And what I mean when I'm talking about that is a child might not be able to consent for their care, but they might be able to assent by nodding their head or putting their hand out for care. So I just think that's something that we need to think about. How do we include them, bring them along, not force them into care? And there's I could do a whole lecture on that, I'm sure. But I don't want to bore you all to tears. And then really just, I'm starting to close up now. This is how both family-centred care and the rights of the child come together. Family-centred care honours the role of the family, but the rights of the child recognises a child as an individual within that system. Promotes shared decision-making, family-centred care, but the rights of the child also supports the child to be autonomous. Family-centred care is always culturally sensitive, so the rights of the child means we're non-discriminatory and we include them, even if we have different religious beliefs or different cultural beliefs. And family-centred care means we support the wider family, and the rights of the child means that we acknowledge the holistic environment of the child, which is normally the family. So I've talked a lot about the importance of communication strategies. So just a few more considerations is to use age-appropriate language, employ tools like art, play therapy, or digital apps for expression. This not only helps the child become immersed in an activity, but it aids as a distraction tool, again, develops trust and allows them to feel safe. And finally, offer consistent and compassionate communication, which of course leads to safe and compassionate care. As we all know, communicating with children is integral to any aspect of paediatric care. So children may express their thoughts or feelings non-verbally. So we also need to listen and observe body language, recognise change in behaviours or participation, and as appropriate, seek guidance and cues from parents. And I suppose my key takeaways, back to one of my favourite photos, is just palliative care for children is not just about managing symptoms, it's about honouring lives, supporting families and respecting their rights. And family-centred care and the children's rights are complementary to care, and they're not to compete with care. And what it does is it leads to ethical, compassionate care, which is family-led. And I think that's probably the most important aspect of both these things. It's really honouring the child and their family while the child's dying. And I'll leave it there. Terima kasih. Lovely to see you all.
Yeah, you're
I hope you found
welcome.
that useful.
Yeah, that's very such informative and comprehensive presentation. Thank you very much for the presentation, Prof. Ali. Okay, for the audience, please hold on for a while before we go to the panel discussion. Let's go to our last presentation. Our third speaker is Dr. Nazir Ahmad, Diploma of Pharmacy, Magister of Philosophy, PhD, Registered Pharmacist from University Islamabad Campus, Pakistan. Dr. Nazir Ahmad is now Assistant Professor and Lab Coordinator at the Department of Pharmacy, Abbasian University, Islamabad Campus, Pakistan. And he finished his Doctor of Philosophy in Pharmaceutical Science at Gajah Mada University in 2024. And he also became the awardee of the International Fellowship Program of Gajah Mada University. His research expertise is on the neuroprotective effect of natural products against neurodegeneration, research and development for natural products, nutraceutical and cosmeceutical of natural origin, preparation of standardized herbal extract, enriched with active constituent using green approaches, and also production, quality control, and quality assurance of natural product. Ladies and gentlemen, allow me to welcome Dr. Nazir Ahmad, Diploma of Pharmacy, Magister of Philosophy, PhD, Registered Pharmacist, to present the material. Dr. Nazir, the time is yours.
Terima kasih Ibu,
Yeah.
banyak terima kasih.
Yeah, it seems that you can speak Indonesian, right?
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Waalaikumsalam warahmatullahi wabarakatuh.
Selamat pagi semua.
Selamat pagi.
So I can share my PowerPoint here first.
Yeah, please.
First of all, I would like to say thanks to the committee members who choose me for this conference today. So I would, without wasting time, first I would start the presentation that is on the palliative care. So actually the palliative care, it is involving here in my presentation pharmacological intervention. So the major role will play science, compassion, and practice. So here I will discuss about pain and opioids and some other interventions that are the important part of palliative care. So I would start from the palliative care. I can introduce what is, first of all, I want to know my voice is clear, audience. Am I audible clearly?
Yes.
Okay, thank you. So let's move toward the palliative care first. Palliative care is merely a discipline, merely a medical discipline. It is a philosophy of care. Sorry. Palliative care is not merely a medical discipline, it is a philosophy of care. So in philosophy of care means that we just not only have to treat the patient. For example, a patient has pain. We do not only have to give the pain relieving medicine. We have to educate the person. We have to be with the patient. Mentally and physically, we have to support a moral imperative and a human right. At its core, it seeks to improve the quality of life for patients. The main target of palliative care, and especially when we intervene with the pharmacological treatment, so the main target is quality of life for patients and their families facing life-limiting illnesses such as cancer, heart failure, and chronic obstructive pulmonary diseases. So these are the life-limiting illnesses. For that, we have to convince patient, counsel patient, provide pharmacological treatment. So all things we will discuss here. The palliative care, in another sense, is not merely a medical specialty. It is a comprehensive and compassionate. Compassionate mean that to be with the patient, to support spiritually, mentally, and physically, that address the physical, emotion, psychological, and social and spiritual suffering associated with life-limiting illness. Let's move toward the role of pharmacological support in palliative care. Pharmacological support is one of its keystones, providing relief from distressing symptoms including pain, breathlessness, nausea, anxiety, and enabling dignity at the most vulnerable stage of life. It is about precision, empathy, and personalization. What can be the precision? For precision, we usually see the right drug, correct dose, and most suitable route of administration for the individual while avoiding unnecessary polypharmacy or harmful side effects. So this is our main target, to choose the right drug, correct dose, and the most suitable right, and avoiding the polypharmacy and side effects. This is the precision. And what is empathy? Empathy, understanding the patient's lived experience, their fears. You know, some people have fear about injection, some people fear of oral medicine. So all these type of fears are fears of pain or fears of disease, their cultural background, and tailoring care accordingly. What does the patient really want? We have to know. This is called empathy, relief, that how much patient is relieving the relief, clarity, peace of mind, a chance to say goodbye. Personalization, it is the recognizing that two patients, they are not same. Some patient can have taking the pain relieving medicine, they have no complications, but some can face some complication related to their disease, related to the side effect of the disease. Their needs, values, responses to treatment vary. For example, one patient may find opioid sedating and uncomfortable, while another finds relief and clarity. The foundation of evidence-based pharmacotherapy. So overall, we will deal here the pharmacology, medicine, and the pain. But we will start from the pain management, the role of opioids and beyond. Pain is the most common and feared symptom in palliative care, especially among patients with cancer and advanced organ failure. So opioids such as morphine, fentanyl, oxycodone, hydromorphone, and methadone remain the cornerstone of managing moderate to severe pain. So when we have to treat the pain, the opioids come on the top. We always give priority to opioids, and especially there are sometimes cardiac pain. So that is only treated by opioid administering. Modern science has moved beyond simply administering morphine. We now understand the importance of opioid titration, means gradually increasing doses based on patient response while minimizing adverse effects. Opioids rotation, switching from one opioid to another with tolerance when tolerance side effects or poor efficacy develops. So we have to switch with the other opioid so to avoid the tolerance side effects and the poor efficacy. Multiple route of administration we can use based on the we can use opioid based on multiple route and the patient need. There can be oral route, transdermal route, subcutaneous route, intravenous, and even sublingual, or sometimes or we can say the buccal route when patient have problem in the swallowing. Adjuvant medications are multimodal strategies. Yes, here is the main point. Sometimes opioids cannot give the proper treatment that we need or that we required. So for that case, here we will discuss about another option for after opioids. So here we will see first the neuropathic pain, which results from nerve damage, common in cancer, diabetes, or shingle. The below picture is showing the shingle disease. Actually, this is result from the viral. This is herpes simplex virus. So that cause shingle, and due to this reason, nerve ending disturbed. So due to this, there is huge pain, and that cannot be treated by opioids. So for that, we have to seek other options. So here, opioid may respond poorly. Instead, we turn to, so when opioid, we are not getting the target our treatment. So then we will move toward the gabapentinoids, gabapentin, pregabalin, antidepressants like duloxetine and amitriptyline used for their analgesic properties. Corticosteroids like dexamethasone are used not only for pain, especially bone or neuropathic pain, but also to reduce inflammation, edema, and fatigue purpose. Antiemetics, if we talk about, are critical for managing nausea and vomiting due to chemotherapy. So this is a big sign of nausea and vomiting from chemotherapeutic drugs. So bowel obstruction or organ failure. Drugs like metoclopramide, haloperidol, ondansetron, and olanzapine are used based on the cause and receptor involvement. Then other drugs that are anxiolytics and sedatives such as lorazepam and midazolam are used to manage terminal agitation, anxiety, and dyspnea, particularly in end-of-life care. Rational pharmacological prescribing, the art within science. So here the role of science is going to start. So science does not simply mean adding more medications. It also means using them rationally. So science always say the use of drugs should be rational. The principle of rational prescribing asks, is this drug necessary? Is it the safest and most effective option? What are the risks of polypharmacy, drug interactions, or organ dysfunction? Is the treatment goal symptom control, sedation, or quality of life exist? This principle becomes even more crucial when dealing with frail patients, older adults, or those with renal and hepatic impairment, where normal pharmacokinetics are altered. Balancing relief with responsibility, the global opioid dilemma. Scientific practice in palliative pharmacology must also engage with the broader public health issues. The global opioid crisis, particularly in North America, has led to increased scrutiny and fear around opioid use, even in palliative care. Here, science plays an advocacy role to show through data and guidelines that when used appropriately, opioids and other symptom relieving drugs do not hasten death, they restore dignity. Integrating research into practice. Science is not static. Ongoing research in pharmacogenomic, non-opioid pain therapies, cannabinoid-based treatments, and delivery technologies like patient-controlled analgesia or continuous subcutaneous infusion is shaping the future of palliative pharmacology. The second is the compassion. Compassion, the heart of holistic care. Yet science without compassion is sterile. In palliative care, we must treat not just the body, but the whole person, their pain, fears, hopes, and spiritual distress. Treating the whole person, not just the illness, pain, nausea, or anxiety can be measured, charted, and medicated, but suffering is subjective and deeply personal. What one person finds intolerable, another may accept it. For example, a patient may report increased pain not due to disease progression but due to grief, fear, or isolation. Another may refuse medication because fear becoming a burden or worry that accepting opioids means giving up life. In such circumstances, compassion means not rushing to prescribe, but instead pausing to ask, listen, and understand. Listening actively, respecting values and choices. Compassionate pharmacological care requires active listening to hear not just what patients say, but what they mean. It means asking questions like, what are you most worried about? What does a good day look like for you? What are your hopes for this time in your life? Only when we understand patient values, we can truly align our pharmacological choices with their goals of care. For example, for some, that may mean maximal symptom control, even if it causes drowsiness, while for others, it may mean staying awake and alert, even if that means enduring some discomfort. Cultural sensitivity and compassionate education. Compassion must also be culturally sensitive. In many communities around the world, pharmacological intervention, especially opioids, are surrounded by myths and misconceptions. That morphine is only for the dying, that it causes addiction or hastens death, that accepting medications means giving up hope. These beliefs are not barriers, they are windows into the patient's worldview. Compassionate clinicians does not dismiss them, but rather engage with empathy. This empathy might mean involving family or religious leaders in the discussion, providing clear, culturally appropriate explanations about the role and safety of medications, gently correcting misinformation while honoring the person's belief and autonomy. Such engagements builds trust, and trust is the foundation of effective pharmacological care. Here, I can add just one more example in coronavirus in COVID-19. So most of the people were scared that when they will take vaccine, there will be some complications. It can be creating cardiac issue. It can affect on the physical health, or later it can create the infertility. So actually, there was need of the counseling. It was to add the palliative care so that patient, not patient, those who will affect or who are affected, they should get vaccine. They should get counsel and trained so that they can not face any problem related to the coronavirus attack in future. Shared decision making, co-creating the care plan. One of the most compassionate acts in medicine is to share power to recognize that patient is not a passive recipient of care, but an active participant in decision making. This is where shared decision making becomes essential. It invites patients and families to express their priorities, fears, and expectations. It ensures that treatment plans are not just clinically sound, but also personally meaningful. In practice, this could mean choosing to taper off certain medications as the patient nears end of life, using low dose sedation for patient who is suffering intensely and consents to this option, adjusting the timing or method of drug delivery to match the patient's comfort and routine. Shared decision making empowers patients and respects their dignity even as their condition progresses. Compassionate presence, being there, not just doing things. Compassion is found in sitting quietly with the patient who is scared, holding space for grief, for silence, for uncertainty, showing up with patience, humility, and humanity. Sometimes, despite all medical interventions, suffering still persists. In these moments, it is compassion, not medicine, that becomes the most powerful form of healing. So this is called actually the palliative care. With medication, we have to counsel the patient. We have to know the values of a patient. The last, the third option, not last, is the practice, global models and challenges. So here, high income countries in many high resource nations, such as those in Western Europe, North America, and parts of Asia Pacific, we see well-developed models of palliative care that integrate pharmacological support as a central pillar. So these systems often feature interdisciplinary team, including pharmacists, physicians, nurses, social workers, and chaplains. Ready access to essential medications, including opioids, antiemetics, anxiolytics, and adjuvants. Robust clinical guidelines, palliative care pathways, and electronic prescribing system. Strong regulatory and ethical frameworks to ensure safe and responsible medication use. In low and middle income countries, a different reality. It's kind of opposite. In many LMICs, the challenges are even more formidable and deeply systemic. Limited access to opioids. In over 80% of world, people have little or no access to morphine or other essential analgesics. This is often due to restrictive drug control laws that prioritize preventing misuse over enabling access, lack of supply chains to distribute medications reliably to healthcare facilities, bureaucratic prescribing requirements that discourage physicians from ordering opioids. Insufficient training. Many healthcare providers in LMICs receive minimal or no education in palliative care during their medical or nursing training. As a result, even when medications are available, they may be underutilized or misused. Cultural and social barriers. Beliefs about illness, death, and the role of medicine can significantly influence pharmacological practice. In some regions, pain is seen as a spiritual test or a natural part of dying. Patients may underreport symptoms to avoid being seen as complaining. Together, these barriers create a reality in which millions die each year in unnecessary pain and distress, not because we lack the medicines, but because symptoms and mindsets stand in a different way. Emerging solutions, hope, innovation, and local leadership. Despite these challenges, there is still hope. Around the world, dedicated individuals, organizations, and governments are demonstrating that change is possible even in resource limited settings. So global leadership has been pivotal role. World Health Organization include palliative care in the definition of universal health coverage and has prioritized access to essential palliative medicine. The International Association for Hospice and Palliative Care works to expand access by revising the model list of essential medicines, lobbying for regulatory reform, and providing training resources globally. National and local efforts are even more inspiring. In Uganda, appreciation to government collaboration and civil society, nurses have been authorized to prescribe oral morphine. Locally produced liquid morphine is now available across the country, making Uganda a model of opioid accessibility in Africa. In India, the state of Kerala implemented a community-based palliative care model supported by local volunteers and trained health workers, dramatically improving access to pain relief and supportive care. In Mexico, palliative care has been integrated into national cancer programs, and pharmacists have played a leading role in ensuring medication availability and rational use. These success stories reveal a common truth: with political will, public awareness, and professional education, pharmacological support can reach even the most underserved. Bridging gaps through global solidarity and policy reform. The global community must address several key priorities. Here first will come the policy alignment. Drug control laws must be updated to strike a balance between preventing misuse and enabling compassionate access, training and capacity building. Health workers must be equipped with the skills, confidence, and ethical grounding to prescribe and manage pharmacological therapies in palliative care. Public education. Myths and stigmas must be countered through culturally sensitive outreach and patient empowerment. Investment in research. LMICs must be supported in building local data and research capacity to adapt global best practices to their own setting. A holistic approach in integrating the triad. Now, actually, this is the overall summary I'm going to share. So, what does a holistic approach truly look like? It is the seamless integration of science, compassion, and practice. In science, we are ensuring medications are safe, effective, and tailored to the patient needs. In compassion, recognizing the human experience behind every prescription. Practice building systems that support accessibility, equity, and sustainability. Science, a foundation of grounded in individualization. Every patient metabolizes drug differently. Science says every disease trajectory varies. Every symptom has a context. Thus, science must serve the individual, not the protocol. Compassion, the ethics that guides every decision reality. While science informs us how, compassion reminds us why. Why do we titrate medications so carefully? Why do we spend extra time educating a family about opioid safety? Why do we honor a patient's wish to remain alert even at the cost of some pain? And the third one is the practice creating systems that enable holistic care. This includes ensuring that essential medications are accessible, training all levels of healthcare providers, fostering interdisciplinary collaboration. Crucially, practice also involves public engagement. Education and advocacy, this can be the last one, the bridging knowledge gaps. Educate clinicians in both pharmacological competency and compassionate care. Need to educate the clinicians, empower patients and families to ask essential questions, understand options, and make informed choices. Advocate with policymakers to ensure national and global policy support access to essential medications and palliative services. The deeper meaning from cure to care. Pharmacological support becomes not just a means of symptom control, but an expression of care. It is a way to affirm life even in its final stage. It is a commitment to relieve suffering even when disease progression irreversible. So this is the last slide where I'm going to conclude my overall lecture today. We cannot always cure, but we can always care. Pharmacological support and palliative care must unite science, compassion, and practice. Tailor medication to individual needs, advocate for access, education, and dignity, ensure care continues when cure is not possible. Thank you.
Okay,
Any
you're
questions?
welcome. Yeah, thank you very much, Dr. Nazir Ahmad, for the insightful information through the presentation. Okay, ladies and gentlemen, that was a very great presentation. Yeah. Now we have come to the panel discussion, question and answer session. Yeah, we are glad to receive question from the audience. Please raise your hand, open your microphone, and mention to whom your question is addressed, or you can write your question in the chat box. Okay, it seems that there are questions in the chat box. Yeah, let me see. Okay, the first question is addressed to Dr. Halisa from Ibu Herianto. The question is, considering Malaysian's culture and religious diversity, how are these elements reflect in palliative care delivery, and what are the key research gaps that must be addressed to strengthen culturally competence gap?
Okay, thank you for the question. Actually, regarding the palliative, I think not be issue in this type of treatment because who taken care of the patient is actually the family of the patient. So when we touch about the religion, so not a big issue, and also this is a very good also in Islamic as example, when we can release the stress or the difficulty of the patient regarding their disease, this is we call a good one. We can get the pahala in Islam. So I think this is not a big issue. And regarding the cultural, I think as a Malay in the Nusantara, this is a very good culture to be practiced, how to taken care of the patient regarding their palliative treatment. Thank you.
Okay, and then is there anyone who raised the hand to ask a question? Nah, yeah, and then we go to the second question. The second question is addressed to Prof. Arison, Prof. Ali. How can healthcare providers help children and their families understand and cope with the concept of death as a permanent separation, especially in developmentally appropriate and emotional sensitive way? And then second, there are two questions. Based on your experience in pediatric palliative care, what strategies do you find most effective when communicating with children about end-of-life issue in a developmentally appropriate way?
I think just understanding the family and what they need and just finding out what's important to them. I think it's really important to start with them and what their focus is. So listening, finding out what their concerns are, and then starting from there.
Yeah. Okay. Thank you, Prof. Ali.
I have a
Then,
question.
okay, Mrs. Hindri, please. Okay, Mrs. Hindri seems have
Hello,
a
everyone.
question.
Hi, Ali. Actually, at first, I want to greet Prof. Ali. It is so wonderful to see you via Zoom after all these years. It's been 10 years actually, Ali, for not seeing you. And I see that you're still so amazing today. Yeah, you look so enthusiasm and still so energetic, like when I did my master's previously. And welcome to our campus at Cendekia Utama Kudus. And actually, I have two questions. The first questions for Ali, and the second one for Dr. Nazir. The first one is that, Ali, how do you think the healthcare providers can effectively balance the rights of the child with the needs and concern of their family members in palliative care, particularly when there are conflicting opinions or priorities, especially in Indonesia, as we see from your PowerPoint, we see that you visited Indonesia many times, and we know that you are as a young professor in Erlangga and Pajajaran University as well. And maybe you know the culture and also the situation in Indonesia. So maybe you can relate this situation in Indonesia. Thank you, Ellie. And then the
Thank
second one
you.
is a question for Dr. Nazir. Actually, what role do you think cultural and socio-economic factors play in shaping the pharmacological management of pain and symptoms in palliative care? And how can healthcare providers in Indonesia take these factors into account when developing treatment plans conducted? I think only two questions. Thank you.
Okay, I'll be quick. Look, Indri, I think it's really hard. You have to try and understand what's happening for the family, and you have to try and understand their perspective, but also then it's about listening and saying, well, if we try this, how does that sound to you? Asking the child, how do they feel? I just do think you just have to just go slowly and be gentle. And it also comes with practice. It's really hard to have the difficult conversations, and it's difficult when the parents may not agree with something that may not promote the rights or the care of their child. But as a nurse, we can advocate and we can say, look, if we do this, this will actually provide that child with more support. Let me give you some time to think about it. We can discuss it tomorrow, and it's those, and I suppose it's about answering the question a little bit before, make sure language is age appropriate, sitting down, not standing up, trying to find a common connection is really important. Trying to get to know the family, understand their circumstances, understand what's going on for them. All of that. And it does take practice. But, I think if we can be polite and kind and listen to other people's needs, that can really help. So I'll leave it there. Thank you.
Okay, thank you, Prof. Ali. And then for the next question, for the second question, if I'm not mistaken, it's addressed to Prof. Nazir, Dr. Nazir, right?
Yes, I think about cultural, social, and economic point of view. If I will discuss, if I compare with my country, the Indonesia is super advanced than that. I know that because I found many of the Indonesian hospital, they are giving access and providing maximum healthcare facilities even to the needy peoples. So when it comes to the society, so I think it should be the educate to the public. For example, if patient it need to help to cure any pain, so they should, being a Muslim, especially in the Indonesia, Pakistan, and some other Muslim countries, they overall they expect on the religious things. Like this can be a spiritual thing, this can be other thing. But when it comes to the society and the culture, so Indonesian culture, if I based on my experience, they are having more you can say open toward the treatment to show their problems with the hospital, with the healthcare staff. And about the society, I think there should be some education, some counseling related to the problem and issues. Like if there is a pain related any issue, they can be sent toward the, like to use any morphine like product, but not like a longer time, because it cause addiction, it cause other problems, it cause other complications, some side effects that can be a lifelong. So by this way, but economically, I think Indonesia is sufficient and providing scholarship each year to a lot of not only Pakistani students worldwide. So it means that economically, Indonesia, I last time I found it's the fifth ranked country among the Asian countries. So if there is need of any like that essential drug provided in the country, so there will be not a barrier. But the major thing is counseling, the education to the patient and to the normal individual regarding the disease, regarding the medication. I hope I answered the question.
Okay, thank you, Dr. Nazir. Okay, the next question comes from Miss Anna. It is addressed to Prof. Halisa, Dr. Halisa. What is the Malaysian government strategy for controlling NCD at the national and local level? And then the next question is the Malaysian healthcare system adequate to handle the increasing burden of NCD? Okay.
Okay, thank you for the question. Now in Malaysia, we focus on the bottom-up strategy, which we involve the public to educate and nurturing them how to avoid the NCD at the early stage. We have syllabus in our school education to educate the youngster and the children at the early stage of their education, how to avoid, how can we be act to avoid the NCD with our daily lifestyle. So this one is one of the strategy. Another one is we use the social media. We know the youngster, the youth is very addicted with the social media. So the Ministry of Education using social media every day they send infographic, one infographic with all the detailed information through social media to educate the young one how to take care of their health. This is a very, I think, very good strategy regarding how to prevent the NCD among the youngster. The second one is, yes, we adequate to handle, but this is because we keep build the new hospital, train our expertise, the young doctors, whatever, but this is not really good one. As I mentioned, we must taken care of our health in nurturing and also educating the public. Instead, we can cope with the burden of NCD.
Okay, thank you, Dr. Halisa. It means that utilization of social media useful, right?
Yes.
Okay. And then we go to the next question. It's
The
addressed
second
to
question, I think, to me,
yeah.
asking about how we can counsel, how we can to know the family patient family that the morphine is we can use or how it can be affecting
Yeah.
for the disease or pain, not for the death. So I would say that actually an ordinary person should not involve in this process because here can be a one lack of medical knowledge. That if any ordinary person is saying that morphine is good for the pain, and the other patient or person is using morphine for any unuseless purpose, then it will cause addiction. It will cause the complications further. So based on my opinion, actually it should be addressed through proper you can say research, medical especially the doctors, pharmacists and the pharmacists. So there should be guided to the families and patients. They should share this information with their family that only for the pain purpose the medication, if we use at appropriate dose, it is beneficial, but it should not be used in excess. The proverb, excess of everything is bad. So when you anything like morphine, especially, will be used long term, it will cause serious complication. So family should be addressed by the doctors, especially on the prime basis with the pharmacy, especially the pharmacist, and even the nurses can also involve in this matter. And the major role can play the government, the national government. So this will also be effective for the to guide the families that using morphine is beneficial, not it will lead to that toward the death if it is inappropriate dosage.
Okay, thank you, Dr. Nazir. Okay, I think it's the last question. Yeah, our last question delivered to Prof. Ali. It's from Mrs. Devi. In the context of pediatric cancer, where the child no longer has parent and how family-centered care be effectively implemented. And yeah.
Great question. I think it's just important to be kind. I mean, family-centered care is about care and compassion and including the child and, in just protecting their rights. So it's really just about thinking about perhaps what would I like? How would I like to be looked after? How would I like to be treated? How can I give the best care? I mean, family-centered care is important because most children live in some kind of family. It might not be a traditional family with parents, but they'll have some people around them that know them and who want to advocate for them, and how can you uphold their wishes. So I think it's just about being kind and thinking about that person's rights. If I was lying in that bed, how would I want to be treated?
Okay,
Yeah.
thank you, Prof. Ali. So the key point is being kind. Yeah. Yeah. Okay. Apparently, we still have a numerous question or topic to be discussed. However, due to the time, we need to end our discussion session. Yeah, ladies and gentlemen. We have finally come to the end of this international conference. Some highlights from today's conference are nowadays palliative care actually is crucial issue regarding to the increasing chronic disease, and palliative treatment does not aim to cure, but it improves the patient's quality of life by managing pain, emotional distress, or discomfort experience due to the chronic illnesses. It's not just for cancer actually, it's not just for cancer patient, but for all NCD or non-communicable disease, patient who has experienced serious suffering, whether physical, emotional, or spiritual. And as a health workers, we cannot always cure, but we can always care for the both of the patient and also the family. We can optimize caring the patient with life-limiting illnesses by using palliative treatment or palliative approaches. Okay, ladies and gentlemen, I would like to thank the speaker, Prof. Ali, Dr. Halisa, and Dr. Nazir for a great, informative, and interesting presentation. Thank you a million. Yeah, thanks a million for sharing the knowledge with us today. It means a lot to us. I also appreciate all of the participants for your engagement and active participation. And I look forward to seeing you again at the next event. Before I end this presentation, please give applause for all our speakers. Okay, thank you very much and have a great day. Assalamualaikum warahmatullahi wabarakatuh. I give the time back to Master of Ceremony. Oh ya, ini ke Master Ceremony.
Thank you to Professor Ali Sanatan, Dr. Haliza Abdul Rahman, and Dr. Nazir Ahmad for the material presentation and discussion. Thank you to Mrs. Arina, who guided the presentation too. The next agenda is the granting a certificate. We have had the pleasure of listening to our distinguished speaker, who has shared with us their insights and expertise on a very important topic. We are very grateful for their time and generosity. As a sign of our appreciation, we would like to present them with a certificate of recognition for their valuable contribution to this event.
Certificate.
The first certificate is presented to Professor Alison Hatton, registered nurse, Diploma in Applied Science of Nursing, Bachelor of Nursing.
Okay, this certificate is presented to Professor Alison Hatton, registered nurse, Diploma in Applied Science of Nursing, as first speaker. And then, thank you, Prof. Ali, for your knowledge. It means a lot to us. Thanks a lot for your time. I wish we could meet you in person here, but we only can meet via Zoom meeting right now. And then the second certificate is dedicated to Associate Professor, Dr. Halisa Abdul Rahman, PhD, from University Putra Malaysia.
Thank you very much.
Yeah, thanks a lot for your contribution today, Dr. Halisa. And then the next, this certificate is presented to Dr. Nazir Ahmad, Diploma of Pharmacy, Magister of Philosophy, PhD, registered pharmacist as the third speaker. Thank you very much, Dr. Nazir, for your contribution today. Okay, I will give time back to Mrs. MC.
Thank you, Mrs. Arena. Ladies and gentlemen, we have reached the end of agenda. Let us close this event with reciting Hamdalah together. Alhamdulillahirabbil alamin. I hope you have enjoyed the stimulating presentation, insightful discussion, and fruitful collaborations that took place over the day. I am as the Master of Ceremony. We would like to thank all the speakers, sponsors, organizers, and I hope you have enjoyed the stimulating presentations, insightful discussion, and fruitful collaborations that took place over the day. I am Fika Izati Fizla as the Master of Ceremony would like to thank all the speakers, sponsors, organizers, and participants for making this event a success. I wish you all a safe journey back home, and I look forward to seeing you again at the next edition of this conference. Please forgive me if you found a lot of mistakes. Thanks for your attention. And the last I say, wassalamualaikum warahmatullahi wabarakatuh.
Thank you.
Thank you. Oh,